It's just
Sure.
past 7. So, ladies and gentlemen, welcome to another edition of Thoughtful Tuesdays webinars. These were webinars that we started with an aim of addressing things that are not that common in day-to-day practice.
No?
And when you go to conferences and things, often there is no time to discuss things at
What are
length.
you saying?
So that was the reason why this
Hungry or not?
series of webinars were started, and they have been going on, and they have been useful. A lot of these, even if you don't attend now, are available on YouTube. So the ones that have happened previously are all accessible on the IAPS Society YouTube site. So this edition of the Thoughtful Tuesdays webinars will be delivered by Dr. Sripathi. Dr. Sripathi is well known to all of us. He is a very articulate, very well-read, and very good communicator. A pediatric urologist who's been in this specific field for a long time and probably is involved with a very broad gamut of pediatric urology. Along with Dr. Suresh from Mediscan, they have also been involved with fetal work as far as urology is concerned. So the topic for today essentially is about how to manage children who have got antenatally diagnosed urological anomalies, specifically lower urinary tract obstruction. So I invite Dr. Sripathi to please deliver his talk.
Thank you very much, Sanjay, and I truly appreciate being called on this for this Thoughtful Tuesday, which is an excellent initiative as far as the IAPS is concerned. And actually, Dr. Sanjay gave me a very broad topic. He said antenatal diagnosis, management, counseling, and perinatal management of the urinary tract. And that's a huge topic. So what I've done is I've basically taken up only antenatal diagnosis, management, and also counseling. Dr. Sanjay was very clear that counseling has to be spoken in detail, and I completely agree with him. For lower urinary tract obstruction, which will heretofore be referred to as LUTO. Could I request people who are could I request the participants to mute themselves, please? Because otherwise, there is talk of dinner and things like that, which makes us very hungry. I'm sorry. So when you talk of lower urinary tract obstruction, you're essentially talking of posterior urethral valves, which are seen in males, anterior urethral valves, which are seen in males. So a lot of people forget that anterior urethral valves can be as obstructive as posterior urethral valves, and as devastating in their effects. Uretroceles in both sexes, especially ectopic uretroceles, which obstruct the bladder neck, and of course, the rare urethral atresia. So we'll straight away start the topic. How do you make a diagnosis of LUTO? What do you consider as the antenatal parameters to diagnose a lower urinary tract obstruction? This is a clinical score for antenatal diagnosis of LUTO. And basically, when you have a score of more than 9.5, the risk of LUTO is 96%. So a large bladder, a severe megacystis will give you 4 points. If the ureters are dilated and can be seen, you get 1.3 points for every 1.3 for every millimeter of ureteral size. If there is oligo or anhydramnios, you would get a 4. If it's a male child, because of the propensity of posterior urethral valves, you get a 4. And if it's a very early referral, which means that the obstruction is fairly severe, you would get a 4. So this is quite important to know. Now, if you look at the sensitivity and specificity of the various criteria that are used to make a diagnosis of lower urinary tract obstruction, you come across 4 things which again are important: the oligo or anhydramnios, this megacystis, the large bladder, echogenic kidneys. The moment you have echogenic kidneys, that means you're going to have compromised renal function, because echogenic kidneys indicates fibrosis, and of course specific signs like the keyhole sign, which are pathognomonic of urinary tract infection, pathognomonic of posterior urethral valves. My apologies. So the most important index of fetal renal well-being for us is amniotic fluid volume. So amniotic fluid volume still remains an important index as a marker of fetal renal health. Now, how do you come to this conclusion of 8 to 20 being normal AFI? If you take the pregnant uterus and divide it with a vertical line and a horizontal line into 4 quadrants, each quadrant should have a minimal pocket of 2 centimeters of amniotic fluid. So when you combine that, then you get your amniotic fluid index. So if you have 8 to 20, it's normal AFI. Between 5 and 8 is borderline oligohydramnios, and less than 5 is severe oligohydramnios. Though amniotic fluid volume has been considered a poor measure of renal function, there is no doubt that mid-gestation oligohydramnios carries a very high mortality rate. It obviously indicates severe renal compromise. The other markers, this you can find in all textbooks, when you do an amniotic fluid analysis, or if you do a fetal urine bladder sampling, and if you find all this, a sodium of more than 100, a chloride of more than 90, this is in millimole per liter, an osmolality of more than 210, a calcium of more than 8, a beta microglobulin of more than 10, and a cystatin C of more than 1. All this would indicate that the renal health of the child is not great. And this was evaluated in the Pluto trial, but of course the Pluto trial was aborted due to acquisition issues. Now, when you talk of fetal bladder urinary sampling, it's not one sample that is evaluated, but 2 or 3 taps which are done over 5 to 7 days to look at changes in tonicity and electrolyte patterns. And this was way, very far before Alan Flake and Michael Harrison, who were the pioneers in fetal intervention. They said by emptying the bladder repeatedly, urine recently produced by the kidney is assessed and a true idea of renal function is obtained. So this is important to remember. It's not one single bladder urine sample that you take to decide whether the kidney is all right or not. You have to do 2 or 3 taps over 5 to over a week between. So in other words, by the time you complete your 3 taps, you will find that 2.5 to 3 weeks has gone. Now, we looked at amniotic fluid volume. We looked at renal indices in terms of urinary indices. And now we are looking at another important thing called the fetal bladder sagittal length. This is one of the very important factors that you use to decide that the child has an LUTO. One of the simple ways of looking at it is to look at the gestational age in weeks. -5 will give you the normal fetal bladder sagittal length in millimeters. So the simple measurement will help to identify megacystis and possibly PUV. In fact, PUV, the bladder is so big that it's gestational age +2 to gestational age +12. And this was a paper that was written by one of the pioneers in pediatric urology, Max Maisels, in the year 2004 in Journal of Urology. When you see a megacystis coupled with non-cycling, that's a sure indicator of lower urinary tract obstruction. So if you keep observing the fetal bladder, over a period of 15 minutes, the bladder empties and refills again. So it is important to look for cycling. It's not only important to look for megacystis, you also have to see whether the bladder is cycling or not. Another factor that you can use to identify a lower urinary tract obstruction is to look at what is called the fetal bladder shape. Now, there are some shapes that have been diagnosed. The most famous that all of us know is the keyhole sign in posterior urethral valves. Along with that, if you get hydrouretus, you can be practically sure that this child has a posterior urethral valve. In a urethral atresia, the bladder is more circular in shape in a urethral atresia, though you see a dilatation of the posterior urethra also. In a prune belly syndrome, you would get what is called a snowman shape in prune belly. So you're looking at amniotic fluid volume, you're looking at urinary indices, you're looking at fetal bladder size, you're looking at fetal bladder shape. Now we come to the question. So these are the various, we've also looked at the various indicators which tell us whether the child has a lower urinary tract obstruction. Now, we come to the next question. Will fetal intervention improve outcome in lower urinary tract obstruction? And this question was addressed by Glick et al. in the 1980s, where they used a sheep model and did a cystotomy and improved amniotic fluid volume, lung growth, resulting in survival with minimal renal histological change. So this was a landmark event, which then subsequently was applied to human fetuses. And then the question was, what is the reliable index of renal health in the fetus? So this was the first step that was used for antenatal intervention. Now we come to this very important point. What is the importance of counseling? Now, it is important to tell the parents that any form of fetal intervention carries a risk of losing the pregnancy. The key elements, therefore, are careful patient selection, optimal timing. So you have to choose the fetus which will benefit the most from the intervention, and then choose the right time to intervene also. And remember, it should be a collective decision. A careful parental counseling is important. And that's where we as surgeons come in. Mediscan, we are involved in serial counseling of them. For instance, for every fetal bladder tap that they do, they would come and ask you, and we go through the same thing again and again. And there should be no pressure, no indication, no coercion on our part to encourage the parents to either keep the fetus, prolong the pregnancy, or terminate it. We have no role to play. We only have to put the cards on the table and let them make a decision. And we have to help them to come to the right conclusion based on the clinical experience that we have accumulated in looking after these children and seeing them grow. So this is the Mediscan protocol for antenatal intervention in lower urinary tract obstruction. Usually, if there is oligohydramnios, intervention is not considered, and I'll show you why. Now, fetuses with severe associated anomalies are excluded. The fetal karyotype between the first and second taps, 2 weeks apart, the fetal karyotype is obtained to look for any abnormalities in that. A detailed renal scan is done, looking specifically at renal echogenicity, cysts in the kidney, urethral dilatation, and other problems. Only those with deteriorating parameters as far as the fetal urine biomarkers are concerned in the late second and early third trimesters are counseled for intervention. So there have been, some people have criticized us saying that you are intervening at a time when the maximal benefit cannot be obtained. We told you there are practical problems. If you want to do fetal bladder taps 1 week apart and you are need to do 3, obviously you're losing 3 weeks in that. And you really can't be very rigid about saying, if I don't do it before this particular gestational age, I will not get benefit. So before we go ahead, there are some questions that we need to ask ourselves. One of the questions is, are we absolutely sure of the diagnosis? Please remember, there are 23% false positives. For instance, PUV, urethral atresia, Roon belly syndrome are sometimes difficult to distinguish from one another. I still remember in 1989, 1990, at the Royal Children's Hospital, Melbourne, we were discussing an antenatal diagnosis of a child we were very sure was PUV, and it was a Roon belly syndrome after birth. So it sometimes can be difficult to make a diagnosis. Now, PUV, which is the bane of our clinical practice, we see a lot of PUVs. They can present with varying degrees of renal dysplasia, and we should remember intervention may not be useful in all. And we should use fetal biomarkers to come to a conclusion. Then comes the question of what is the correct intervention window? What is the optimal intervention window? If I intervene, you have to ask yourself, if I intervene, will restoration of amniotic fluid volume reverse the effect of the lower urinary tract obstruction? Will it avoid ventilation at birth? For this, you have to intervene before 26 weeks gestational age. Will my intervention create a reasonable renal chemistry? Will my intervention completely avoid the need for renal replacement therapy? Or at the very least, can renal replacement therapy be postponed to the second decade? This is very important, which we need to understand as surgeons. Please remember, when you're putting somebody on a cadaver donor program and a cadaver donor is available, the child should be big enough to accept it. If the entire cardiac output is going into the transplanted kidney, you can understand what will happen to the child. So you need a fairly older child for you to be able to fit an adult kidney into that child. This is the reason why we said, if you can postpone renal replacement therapy, and by renal replacement therapy, I also mean dialysis. So there are two types of transplants that we do, what is called preemptive transplant, where you don't put them on dialysis, so they don't have the problem of acquiring antibodies and rejecting transplants. You just straight away put them on the transplant program and finish the transplant. There's another group which invariably has to go on dialysis and wait their turn for a transplant. So there are some key slides that I will mark out. The first slide is the one that I showed you, the scoring system for LUTO. The second slide was the slide that went just before this. When I intervene, what happens? And this is another key slide that is very important. And this key slide is the staging system proposed by Ruano. Now, this is the staging system that we use extensively in order to make a decision whether our intervention is going to be worthwhile or not. I'll just go through this with you. Stage 1, no intervention needed. The amniotic fluid is normal. There is no echogenicity of the fetal kidneys. There are no cortical cysts. There is no dysplasia. Fetal urinary biochemistry is favorable. Obviously, you don't need to intervene. When you come to stage 4, there is anhydramnios. The kidneys are echogenic. There are cortical cysts. There is dysplasia. The fetal urinary biochemistry is unfavorable. Once you tap the bladder, there is poor refilling of the vesicocentesis. So in this particular case, fetal intervention is not needed. What is needed is amnio infusion in order to prevent problems with compression of the fetal limbs against the uterine wall. That is the only thing that you can do. These children are going to have severe renal insufficiency at birth. These are the Potter type children. Now, we have two stages here now, a stage 2 and a stage 3. The stage 2 is the ideal stage for us. When you have oligohydramnios or anhydramnios, or on serial view, you find that the amniotic fluid is reducing. Then you have fetal kidneys with no cortical cysts, no dysplasia, preferably non-echogenic kidneys. There is favorable urinary biochemistry with 3 consecutive bladder taps. Then fetal intervention is indicated to prevent both pulmonary hypoplasia, which is before 26 weeks, and also prevent severe renal impairment. You can do either vesicoamniotic shunt. You're going to see this word constantly, VAS, or cystoscopy. Again, I request those who have their microphone on, could you please switch it off, please? It's becoming difficult to continue the talk. Now, oftentimes we also see children in stage 3. Now, stage 3 is when there is oligohydramnios, when the kidneys are echogenic, cortical cysts can be present, renal dysplasia can be present. The fetal urinary biochemistry is not favorable after 3 consecutive evaluations. At this particular time, the tapping may be indicated to prevent pulmonary hypoplasia, but not postnatal renal impairment. So this is something, again, that you need to remember. Therefore, when you counsel children and when you look at this, it's important for you to be aware of the Ruano criteria, because your counseling will depend on what stage this child is as far as the Ruano criteria is concerned. Okay, so in this particular case, your intervention will not prevent pulmonary hypoplasia, but will not prevent postnatal renal impairment, but will help to prevent pulmonary hypoplasia. Ideally, we would like stage 3, but oftentimes we also land up with stage 3. Now, this is the Mediscan experience up to 210. The lower urinary tract lower urinary tract obstruction was a 385, and from 211 to 222, it was 350. So that's a number of around 750, which is a considerable experience. And you can see most of the mothers have come in the 2nd trimester for counseling, though a few of them have come in the 3rd trimester, which is a little late as far as any intervention is concerned. Can I also request Dr. Suresh to look at the chat messages in the box and possibly reply to them, please? Now, fetal urinary sampling. Since 2000, 40 fetal urinary samplings have been done for lower urinary tract obstruction. In 13 cases, there was oligohydramnios, a progressive reduction on serial follow-up. The biochemistry was always at normal. The beta-2 microglobulin was more than 6. In 32 cases, Liker was present. In 18 cases, the biochemistry was within the normal range. In 14 cases, there was borderline biochemistry. The reason why I'm putting up all this data is, it's not merely you look at a child, there is obstruction, you go in, you put a shunt, or you do fetal cystoscopy. It's not like that. You have to take all this also into account before you actually go ahead and do an intervention. And this is important to remember. So these are the shunts that are available. What we choose, what we have at our disposal is the Harrison shunt. This double coil is within the bladder. This coil is within the amniotic cavity, and it's flat, and it lies flat on the surface of the baby for the very simple reason that the baby can't pull it out. And this is important, and babies are known to pull out shunts. So how many cases have we done? We have done 8 Harrison double pigtail shunt. All these were mothers who had decreasing Liker on follow-up. One case we have a 16-year follow-up. In one case we have a 5-year follow-up. 2 of them were dislodged. They were removed by the baby. They were not repositioned. In 4, follow-up was not available at the time the presentation is being made. But I think if we search hard enough, I'm sure we will get the data that we want. I just want to show you something very important. This is a picture of how the needle comes in for a vesicoamniotic shunt. The theater setup and how things are done, I will explain when we talk about fetal cystoscopy. I want you to understand that this is the way that it is done. You can see the very narrow window, between a flexed thigh, an umbilical cord which comes down between the legs of the fetus, the hands in between, the baby facing forwards, and you get a very narrow window through which you have to go through the mother's abdominal wall, through the uterine wall, avoid the placenta, avoid the cord, and then hit the bladder. So this is something that requires great skill with the use of both the ultrasound and skill in puncture. So this is something that, that is not to be undertaken very lightly. And I will discuss the complications of vesicoamniotic shunting, some of which are quite horrific. So here is a sort of a slide showing how this is being done. That is Dr. Suresh, who's loading the Harrison double pigtail shunt on the needle. And once it is loaded, you put the pusher behind it, exactly like what we would do for a DJ stent. And the whole thing you load already. He has hit the fetal bladder, and then he pushes the stent inside. So let us come here and see what is happening. So you can see that's your fetal bladder, and that is the shunt coming into the fetal bladder. And he confirms it on ultrasound also. And finally, that is the shunt in place on the abdominal wall. As I said, it is flat on the abdominal wall. And you can see on the ultrasound, the shunt is inside. So the double coil is within the bladder. The single coil is out on the abdominal wall, draining into the amniotic cavity. And you can see an immediate decompression of both the kidneys and the ureters collapsing as well. This is the child who had 16 years has a creatinine of 1.1, and he has minimal B1. So this is one of our success stories. Now, for all the pediatric surgeons in the audience, this was the MCU at 3 months, and I want to show you how the bladder is smooth-walled, and you can see there is no bladder neck hypertrophy also at all. So this is something that impressed me quite a bit. So I was wondering whether if you did a vesicoamniotic shunt in all PUEs, would we avoid the problem of bladder neck hypertrophy in these children, which can be a serious issue. And he had reflux into one defunct kidney on one side. This is the urodynamic study at 2 years of age, showing the PDET absolutely normal in a crying child. The urodynamics at 5 years of age, again, the PDET is normal. And his uroflow at 5 years of age, which was not great. Now, the reason why I'm showing you this is, rather than making a blanket statement saying that the child is completely all right, I think you should see the nitty-gritty of whatever is happening also. So this is real-time follow-up as far as this child is concerned. I still don't have the 16-year follow-up data, but I propose to acquire it very soon. So this was the good outcome. I want to also tell you one of the complications that we had and how we went about managing it. This was a 38-year-old preemie, a post-IVF pregnancy. They came from Punjab. At 25 weeks ultrasound, we confirmed a posterior urethral valve. At 26 weeks, hydronephrosis with grossly distended bladder. You remember the megacystis we were talking about and how I was talking about gestational age -5 giving you the bladder length, sagittal length in millimeters. So this child had a huge bladder, 387.4 centimeter cubed in volume. At 28 weeks, had a percutaneous ultrasound-guided vesicoamniotic shunt. A week later, there was good decompression of the urinary system. And what was really heartening was that the beta-2 microglobulin dropped from 6.5 to 6.1. Now, at 30 weeks, the child developed urinary ascites. So this again says something that's very important. Once the shunt is put in, it is very important upon the operator, in this case, Mediscan and Dr.Suresh, who keep a serial follow-up on this child. At 30 weeks, the child developed urinary ascites, and we found out that the shunt had slipped into the peritoneal cavity of the baby. Rather than being out on the abdominal wall, draining into the amniotic cavity, it was now draining into the peritoneal cavity and creating an ascites. So 150 mils was tapped at 30 weeks. DEXA was started for lung maturation. At 32 weeks, LSCS was done. Immediately after birth, 350 mils was tapped, the baby was ventilated and catheterized. Now we had a problem. On day 2 of life, again we drained the ascites. Under GA, we did a scopy with a 6-7.5 scope, the type of scope we would use for newborn fulguration. We incised the 12 o'clock position of the PUB. We entered the bladder. We visualized the stent and used a 3 French basket to grab the stent and pull it up. Now, before we did all that, we actually did a dummy run to see whether the shunt would straighten out. I was a little worried whether the Harrison shunt would be pliable enough to come out through a neonatal urethra. We did a redo fulguration at 6 months of age, and at 5 years of age, the follow-up, the serum creatinine was 1.4. Again, I'm giving you these values just to show that just because we have done antenatal intervention, it's not as if the kidneys have completely come back to normal and the serum creatinine is below 0.8 or below 0.6. Now, we had one other problem. As we were doing the scopy, we were aware that part of the shunt was inside the shunt was inside the abdominal cavity. So we had increasing ascites and the danger of splinting of the diaphragm. So you can see this picture where we actually put a needle to drain the ascites so that the baby could be ventilated and the surgery could progress. So outcomes of vesicoamniotic shunting from other centers, the Texas Children's Hospital using the Runau criteria, 14 children underwent vesicoamniotic shunting in stage 2 LUTU. If you remember the Runau criteria slide, you'll remember the stage 2 is one of the best times to intervene when you can prevent both pulmonary hyperplasia before 26 weeks and also prevent renal deterioration. So between 18 and 30 weeks gestational age, they have done vesicoamniotic shunt, and the delivery was at 33 weeks, plus or minus 4 weeks. 86% survived. 67 of them had normal renal function. These are 6-month survival figures. So this is very heartening. Now we have moved on to fetal cystoscopy, which we call the new paradigm of management. We now offer fetal cystoscopy and lower urinary tract obstruction, basically for children with oligohydramnios on serial ultrasound scans with disordered urinary indices, where early delivery is not an option. There is still a lot of time, especially for lung maturation, and therefore we do fetal cystoscopy and laser fenestration in utero. And we have done 2 children with posterior urethral valves and 1 fetus with bilateral urethroceles. So one of these mothers was a 25-year-old mother with bad obstetric history. She had had 1 spontaneous abortion and another child with biliary atresia who died. At 21 weeks, she was diagnosed to have the fetus was diagnosed to have LUTO, most probably PUV. You can see the keyhole sign here and the bilateral hydronephrosis, fairly severe. At 27 weeks, there was huge posterior urethral dilatation, by which time we had done serial counseling for the parents with all the fetal urinary biomarkers with us. We found an improvement, and the parents opted for fetal cystoscopy and valve fulguration in utero. The other child was a mother who was referred at 29 weeks for bilateral hydroureteronephrosis. This was a little more dramatic. There was a rapid reduction of amniotic fluid, AFI, from 12 to 8.8 to 6.9. So Suresh sounded the alarm bells and said, we need to do something. At 29 weeks, 5 days, antenatal fulguration of PUV was done. Now the technique is, the OT setup is in an obstetrics gynecology unit. This is important to know. The mother is awake, local infiltration is done, anesthetist is on standby. The fetus is immobilized by pancuronium given in the deltoid. Per abdomen, fetal bladder is punctured with a trocar. A 1 millimeter scope, 0 degree, is introduced. It's a curved fetoscope and directed into the posterior urethra. You can see the curved fetoscope puncturing the mother's abdominal wall, the uterine wall, avoiding the placenta, the umbilical cord, and getting into the bladder and going into the posterior urethra. And through that, we introduce the laser fiber. So a 400 nanometer diode laser fiber is introduced, and contact fenestration of the valve done at a 10 watts energy. So a simultaneous 4D ultrasound of the fetus and a camera visualization is set up. The baby's heartbeat is audible to all, especially the mother. The mother is constantly engaged in conversation. Once puncture is done and the valves are punctured, fetal voiding can actually be seen and documented. The kidneys decompress as we are watching it, and the amniotic fluid volume increases, and it's very satisfying to see. So here is a picture of the real-time setup. Here is an obstetrics gynecology unit. Here is the obstetrician gynecologist making sure we don't do anything bad. Here is Dr. Suresh going ahead with a puncture. We have Dr. Sudarshan here, who's an expert ultrasonologist. The 4D ultrasound has been set up. We have the fetoscope connected to the camera, which is being simultaneously watched. The reason I'm showing this is, I'm often asked, can we as surgeons get into fetal intervention? The answer is yes, you can. But you must acquire a very high degree of skill in ultrasonography, particularly in looking at the fetus with anomalies, for you to successfully carry out these procedures. Because not only should you be adept at seeing what you want to see, you want to guide the needle where it should go. Remember, in the previous slide I showed you, the fetus is just hanging off the cystoscope. It's a paralyzed fetus floating within the amniotic fluid and is hanging off your cystoscope. It can be quite scary, actually. And then you watch as the procedure is being done. Here is the contact fenestration of the laser. Now, where do the surgeons come in? We come in at this particular point. Here is the fetoscope in the fetal urinary bladder. You can see the trabeculated bladder. Remember, this is a very abnormal way to puncture the valve. We are actually going from above, going through the bladder neck. What you're seeing is the bladder. What you're seeing below is the bladder neck. And it's a curved, rigid scope. You can't bend the scope. You have to guide it into the posterior urethra. Once you cross the posterior urethra, you have to tell the ultrasonologist, in this case, Dr. Suresh, you have to guide him past the veru, take him to the lower end of the veru. Then you do your best to see the valves, see where the valves are fused. And there at that contact point, you tell him where to engage the laser in order to make your fenestration. What we do is we give short bursts of the laser and try and create as big of a hole as we can. I just want to show you this real time, how dangerous this can be, because this can very well be the posterior urethra also, in which case you will actually be making a hole in the posterior urethra rather than actually making a hole in the valve. And this is why it is antenatally important to diagnose and make a difference between posterior urethral valves and urethral atresia. If in a urethral atresia you go and try and do this, you're going to land up with a fistula. And this has happened. This has happened, and there is literature evidence of that. So once you have done enough punctures, you have made enough of a hole, what you actually can see in front of your eyes, fetal voiding, and then the kidneys start decompressing. the amniotic fluid volume increases, and you know you have done the job, and you can come out. So that this is the laser fenestration that is going on here. And this is something that I will be alluding to later also. The curved fetoscope does not allow you to go and turn at that particular point. You have to, this is the only sort of vision you will get to do whatever you have to do. This is the current limitation of whatever equipment we have. So sometimes if we want to join the various holes, like what we would do when we are doing posterior urethral valves, when you see the valve and you cut at 12 o'clock, sometimes you make multiple holes with the diathermy and you join all of them together. Sometimes it's very difficult to do that, given the fact that things are constantly moving and it is very hard to keep the fetoscope in one place. And it's the skill of the operator that he's able to do it, this well. So at 31 weeks after the in utero fulguration, the bladder was normal. Filling and emptying was seen. Liquor was normal. The baby was delivered at 36 weeks. You can see how the kidneys have decompressed. The ureters are still dilated. After the baby was delivered, on postnatal day 3, we did a PUV fulguration. Now, at this particular time, I was very sure and very clear. I told Suresh, I want to make sure that we actually have fulgurated the valve and not done something else. So if you'll just bear with me, I'll show you. This is the PUV. We are in the urethra. This is a 7.5 scope. And the valve will just come into view. And that is the valve. You can see as the curtain there, you can see the hole there. This is the hole that we have made. So I was only after seeing this was I sure that we had actually fulgurated the valve and not done something else. And through that, we could get into the posterior urethra and we could get into the bladder neck also. So we did a redo fulguration at 6 months. This was a follow-up at 11 months. The child was voiding well, had no post-void residue on ultrasound. The serum creatinine at 11 months was 0.5. The spot protein creatinine ratio, urinary spot protein creatinine ratio was 0.41. We still have to follow up the child now, and I don't have that follow-up as of now. Now, this was another child who had bilateral uretroceles and had serial fall in amniotic fluid and the uretroceles, and you can see the bilateral hydronephrosis. And Suresh said that we need to intervene. So again, we gave these people in this particular case, there was no choice of actually doing a vesicoamniotic shunt because the obstruction is at the level of the lower end of the ureters. So we had only one option, which was vesicoscopic laser fenestration of the uretroceles. And here is a video. This is a little simpler because this is within the bladder and the uretroceles are quite easy to see. And you start and you have a little more control over how much you can cut. And we punctured, the laser punctured the uretroceles and the uretroceles collapsed as we were watching them. So this, as far as antenatal intervention was concerned, this was very, very satisfying to do. Now, this is the post-uretrocele decompression status, which was very good. Very good. You can't see the, you can't see the uretroceles. This is the ultrasound showing you the bladder with no uretroceles in them. So this is exactly the reason why I said that, whenever you do antenatal intervention, you also have to give a reasonable follow-up. In this particular child, the story was not great. At 6 months of age, the child underwent fulguration of the urethral component of the uretrocele. In other words, there was an ectopic component of the uretrocele which was obstructing the bladder neck, so we had to do a fulguration of that. At 1 year, 3 months, he presented with huge mega ureters. We did a left loop cutaneous ureterostomy. At 2 years, 5 months, his serum creatinine is 2.5 and ultrasound shows cysts in both kidneys, especially in the upper poles. This child is in CKD and needs and is in very careful follow-up with the nephrologist, and we are seeing what else we can do in order to take this child forward. Now, This was a publication in 2005, which was a good publication. The outcome of vesicoamniotic shunting for lower urinary tract obstruction, a 6-year follow-up. 40% were PUV, 40% were prone belly, 20% were urethral atresia. Look at some of these figures. Survival was excellent. Survival at 1 year was 99%. But look at this figure. 34% had a calculated creatinine below 70. Those of you who are familiar with the KDQI, the 70 represents grade 2 CKD, and some of them were below 34% were below the 70 creatinine clearance, which is not great. 22% were transplanted, 44% had respiratory problems, 50% had musculoskeletal problems, 67% had poor growth, 50% had frequent UTI. And I thought this was important as sobering follow-up for us to see in the long term. There was another very good study in 2020, a systematic review of published studies of 355 fetuses undergoing vesicoamniotic shunting and fetal cystoscopy, which was 45. The perinatal survival in the vesicoamniotic group was 57% versus control, which was 39. Postnatal renal function in a 6-month to 2-year follow-up was better in the vesicoamniotic shunted group versus control. In fetal cystoscopy versus control, normal renal function at 6 months was seen at 38% versus 16%. So just looking at some of these percentages, it looks like fetal cystoscopy is a good option to look at. Now, this is sobering and very important for us to remember. The complications of vesicoamniotic shunting, particularly vesicoamniotic shunting and fetal cystoscopy also. The first of these is maternal, chorioamnionitis, premature rupture of membranes, intrauterine death. Fetal complications are a staggering 54%. Shunt migration, vesicoamniotic shunt, 38% of cases. You can see I showed you how the child keeps the thighs flexed, and it's very easy. Instead of going into the small area between the umbilical cord and the penis, this particular shunt has gone into the thigh, has missed the femoral artery, but it was a close shape. You can have omental or bowel herniation as shown in this picture. And in this particular picture, you can see a shunt has been tied around the umbilical cord. I told you before, when you have a urethral atresia and you try and do a laser fulguration, you can develop a urethral perineal fistula. And you can 25% urinoma with urethral perineal fistula. Bowel perforation is rare, and there is a staggering 30% technical failure. And this is quite common. It's not uncommon at all. So before anybody gets into this, they have to remember all these particular factors, but with persistence, with adequate training and determination to get there, I'm sure you can get into it. Apart from all this, there are some late problems with shunting. Vesicoamniotic shunt, because it suddenly decompresses the bladder, ultimately can result in poorly compliant bladders by eliminating cycling. So there is an answer to this. I will come to it a little later. Also, this is something that we also know. Early shunt placement does not prevent late onset renal dysplasia, which means even after your shunt is placed, the kidneys can continue to deteriorate. So when you counsel, you have to be very much aware of all these factors and not give the parents too much of what do you call that, unjustified hope. So this is something that I would like you to consider. What we need is a flexible fetal cystoscope. You remember the fetal cystoscope that we have, I showed you, is a rigid C, where if you go into the posterior urethra and then you negotiate the 117-degree angle between the bladder neck and the posterior urethra and lower urinary tract obstruction, your maneuvering space is very little. On the contrary, something like the adult flexiscope, if at that particular point, you can straighten the scope and also bend it at will, you can actually see the valves and the point of union, and your guided laser fulguration will be that much more accurate. So a flexible fetal cystoscope is what we should be looking at in antenatal intervention. The other thing that is becoming popular are low pressure valve shunts, like what they would use for CSF drainage, which will enable bladder cycling and not allow the bladder to collapse in one shot. Or The other option is to use shunts which can double as vesicostomies in postnatal life. The vesicoamniotic shunt that I showed you, the Harrison shunt, has to be removed. Whereas if you have a shunt which can double as a vesicostomy, then you can continue with that, and then you can get into newborn fulguration whenever you want. There is no hurry to do a newborn fulguration. This is important for those surgeons who are not very confident or do not have the equipment to do a good newborn valve fulguration. Now, when you look at fetal surgery, description of fetal surgery for lower urinary tract obstruction, what has been described as very effective in decompressing the upper tracts as a vesicostomy. Therefore, if you have a shunt, which can also double as a vesicostomy, you can actually avoid in utero surgery. So this is the reference, one of the references in 2021. Now, further research, future research is renal histology in lower urinary tract obstruction. That is where the focus should be, to understand what exactly is this concomitant renal damage that we are talking about. The million-dollar question that we have, which we don't have an answer to, is renal parenchymal damage really secondary to obstruction, or is it a primary embryological defect in nephrogenesis? In other words, when we go in to put a shunt in people who have decreasing amniotic fluid and decreasing renal indices on serial follow-up, are we actually dealing with short kidneys? Now, the answer to this is partly provided by one of the research programs at Mediscan, where they took fetuses who had been aborted, fetuses with PUJ who had been aborted for various reasons, fetuses with lower urinary tract obstruction which had been aborted, and looked at these fetal kidneys for the number of glomeruli in yellow, in the interstitial fibrosis, then the cortical cyst, oligohydramnios, and increased echogenicity. And interestingly, they found that in PUJ obstruction, the number of glomeruli was far higher than in children with lower urinary tract obstruction. In other words, even at the time that we are intervening, these kidneys have lower number of glomeruli, have a lot of stage 2 interstitial fibrosis. So it is little surprising that the renal outcome, in spite of very early shunting, is not as optimal or as good as we would like it to be. They also looked at the correlation of liquor volume and the degree of fibrosis in the same set of people. And they found that those who had oligohydramnios had more severe fibrosis in the interstitium of the kidney, as opposed to those who had normal liquor. In other words, liquor volume. You remember, this was the first thing we started off with. I started off by telling you that liquor volume is a poor predictor of renal health. On the contrary, Mediscan has now showed us that liquor volume has a 100% positive predictive value to predict renal fibrosis on histopathology. And this is something that's very important for us to know. So in summary, when you select a case for shunting, either a vesicoamniotic shunt or putting in a fetal cystoscope and doing a in utero fulguration, should you choose oligohydramnios? Unfortunately, it's too late. Should you choose somebody for normal amniotic fluid? Is it too early for this? Now, this is not, what do you call that? It is not as outlandish as it sounds. In fact, I remember a meeting in which Philip Ransley, one of the pioneer pediatric urologists in the world, said that we should be looking at putting shunts in all children with normal amniotic fluid. If you remember the MCU picture that I showed you of a child who had a vesicoamniotic shunt done, and I showed you how normal the bladder looked and how normal the bladder neck looked, maybe shunting children with proved LUTO in spite of their amniotic fluid status may be the way to go. Possibly if you can get a low pressure shunt which will not decompress the bladder very quickly. Currently, the only thing we can do is not follow these two, but rather do shunts in those children who have reducing amniotic fluid and falling renal indices on serial scans. So, but then what we do know is therapy may not improve renal function, but definitely improve survival. I have shown you enough data with regard to that. In this particular group, you really can't do randomized controlled trials. It would not be ethical. And it appears that fetal cystoscopy and in utero laser fulguration may emerge as a better option, but obviously needs much more expertise. So I thank Dr. Suresh and the Mediscan team for giving me the opportunity to share their data with all of you. And I thank all of you for your attention. Thank you.
Thank you for an excellent discussion, and very to the point. As I said, you have sort of answered all my wishes as far as what this content of this talk was supposed to have. So thank you very much. I think the nail was on the head exactly. I think there are some questions in the chat box. Dr. Suresh, I can request him to unmute himself.
Yes.
And I think there are some questions on the chat box. We'll go through that first, and then if there are other questions, people can unmute and ask themselves. So I think the first question here is from Akshay Kalawant. What is the preferred management by your team? A vesicoamnionitic shunt versus fulguration, any particular criteria? I think you have spoken about that already. So your choice is a fulguration?
Actually, the fulguration is a more recent development. For many years, we are doing only vesicoamnionitic shunting. Unfortunately, as you said, more than 50% of shunts have the issue of complications. So more recently, there is a new shunt which has come into the market, which is called as the Somatex shunt. The Somatex shunt, we have just imported those shunts, but unfortunately, the cost of each shunt is 1,46,000 rupees, just the cost of one shunt alone. But that is supposed to, the literature, recent publication in 2022 has shown that the Somatex shunt stays for a longer time, the complications are lesser, and also the renal function is better than the other shunts that are there. Compared to that, fulguration is a much less expensive. If you have a 1 millimeter scope, the challenge, as Sripathi said, is to get into the post-urethra, and that also the timing when to do it is the problem. Ideally, they say you should do it before 26 weeks. Before 26 weeks, it's better. But the problem is before 26 weeks, we have some baby with a good liker. So should we intervene? Should we not intervene? And suddenly we find at 28 weeks, the liker is going down. So this is always a dilemma. And as far as fetal urine function is concerned, the renal function with biochemical parameters, we found invariably, if there is oligohydramnios, you will get bad results. If there is good liker, you will get good results. So finally, there are many centers who have literally given up on doing the routine biochemistry, which was what was there before. So these are changing thought process. So fulguration versus when I say shunting, fulguration, provided we have the expertise and the fetal position and the necessary infrastructure to do it. That's better because it's a more natural kind of a thing to do.
Thank you. Then I think there is a question. I'm sorry, I'm unable to say the name, Dr. Mugabe. With the patient with PU while ablated in utero, when was it indicated to do urodynamic studies, or was it not indicated?
I think I can take this question. Suresh, thank you very much for joining. I think for urodynamics, basically what we do is we would like to do a urodynamic study on these children. Essentially what we do is if we find in PUV, if the renal growth is satisfactory, if the nadir creatinine is low, the accepted number is less than 0.8 within 1 year of age, and the child otherwise does not have urinary tract infections, does not dribble, we actually don't get into urodynamics. Because as a country where resources are scarce, we really can't get them to do urodynamics periodically. So what we would do is, if there are symptoms, if there is, say, poor growth of the kidneys, there is increasing hydroureteronephrosis, there is a persistent post-void residue in spite of giving alpha blockers, or you find new onset symptoms, recurrent UTI, those indications are very clear. That is the time that you would do urodynamics.
Thank you. Rasik had a question. Rasik, can you unmute and please speak, Rasik?
Excellent talk. Enjoyed. Dr. Sripathi as well as Dr. Suresh. I think the recent literature says that insertion of catheter through the urethra into the bladder is better than doing anything else. Any literature on that? I mean, any?
Sir, in utero bladder catheterization, it is not possible to catheterize through the urethra from outside. Not yet, because we don't have the necessary, even using fetoscopy, we won't be able to do that. But antegrade bladder catheterization has been attempted. And a few centers have attempted, very few cases, but it has not become very popular because of the, it's technically very challenging procedure. So we are still not there as far as the bladder catheterization is concerned.
Okay.
Rasik, a lot of people say all this, but I'm really scared, Rasik, because when you fulgurate in utero, the first thing I did when the baby was born is lift the penis and see whether we have made a fistula in the urethra. So you can imagine at that sort of bend, for you to put a catheter from above and expect it to come out of the penis, I think is a leap of faith. Something that I wouldn't really try at all. But there is a publication with a picture of that.
Okay, we did. I mean, we had only one experience of doing this cystoscopic, means vasicoscopic ablation, whatever, integrate. We did try to put the catheter, or not even catheter, just a guide wire. It was not possible. Difficult.
Because you can't have enough pressure. You don't have enough pressure to push it through.
Right.
Doing it from a very remote location, you don't have enough pressure to go through. Then I can also say that flexible fetal scopes are being developed now. It is, I just heard that the preliminary results are promising. So you will have a scope which is semi-rigid. After going inside, the tip will be able to change the angle and go inside. That is, it's still, they're not letting the secret out, but I heard that some preliminary results are very promising.
Okay, thank you, sir.
There is a question about, there's a 25% urethral perineal fistula rate, Dr. Sujay Pal mentions, and how do you manage them? Is it that high, 25%?
No, that's at least the published value of that. And I think a lot of complications of shunting or any of these procedures is not really, a lot of them are not reported. But it's very possible. For instance, if you, like I said, if you don't recognize and you don't really, you're very keen to do an antenatal intervention, you actually have a urethral atresia, you still feel you can go ahead and do something, you are going to create a fistula. So it will become a fistula. Essentially what it will do is, it will become a fistula between the posterior urethra and the skin. And you can imagine how difficult it is to tackle it.
So a corollary to that is, the thing is, the diagnosis of posterior urethral valves is many times they have shown that after they go inside, they find it's actually urethral atresia, not a posterior urethral valve. So the differentiation between these can be very challenging in some cases. And if you attempt to go and do a fulguration in a urethral atresia, you will land up in a fistula. Definitely land up in a fistula. So that is so in such cases, what they do, once they identify that it is not urethral valve, but it's actually a urethral atresia, they withdraw the scope and then just place a shunt and come out.
Thank you. There is a question, I'm not sure, I'll just read it out. Are there any studies where vesicoamniotic shunts or fetal cystoscopy has been done in fetuses with good liquor, and compare them to observation versus postnatal fulguration in a good liquor situation? Are there any observational studies or RCTs? It's
a very good question, sir. Actually, one of the principles of fetal therapy, which was laid down by the International Fetal Surgery Society many years ago, is any fetal surgery should be an alternative to fatalistic outcome. That is, if you don't do something in utero, this baby is definitely going to die. So it was aimed at survival and not the quality of survival. So they did shunts for hydrocephalus, they did so many things, The aim was to make this baby survive at birth. In a posturethral valve, the babies were dying in utero because of pulmonary hypoplasia. So the objective of shunting was only to prevent pulmonary hypoplasia, and the renal function was not the consideration. So, and that's why they said babies with Liker anyhow will survive at birth. So they said there's no indication of putting a shunt doing that. This is how the story started. And all the initial studies were with anhydramnios. They were filling up the Liker with saline and then putting the shunt inside. Till such time they realized that this is a futile exercise because none of these babies were doing well after birth, even though the survival improved, but renal function was very bad. And that's how this thing gets. So in most centers today, the selection for shunt is mostly in the Western centers is by patient choice. They explain this thing and then they say, patient, no, I want to undergo a shunt. They do a shunt based on that. So many of the shunt recent thing which they have shown, you'll find their normal Liker itself shunt has been done. And so we know that if there is oligo, putting a shunt is a complete waste of time. So if at all you're doing a shunting, you have to do. So where do you draw the line? Is I keep doing serial scans every 2 weeks or so, and suddenly I find the Liker reducing, but still Liker is there. That is the patient you choose because that is we call it as a deterioration point. Now, the fallout of that is I still don't know how much of renal function I can save because I don't have a trial which can tell me that very clearly, but certainly it will improve survival at birth.
There is a question from Dr. Sareen. How many centers across the country are actually doing these procedures?
So for shunting now, there are a number of centers across the country. Almost every state has somebody, most of the states, at least about 15 to 18 states in India, they will be able to do intrauterine fetal procedures because the number of fetal medicine specialists has grown over a period of time. Now, one of the other things, it all depends on the volume, the expertise and the outcomes based on the volumes which they do. So availability now is much better than what used to be before.
Okay. The other question, Dr. Balmurugan is asking, how do you confidently differentiate between PUV and urethral atresia during scoping?
Yes. So once you put it inside, when you see the PUV, the area will be seen as a thin wire, as we showed in the scope. The area is very easy, and if it is a urethral atresia, then as I go into the bladder neck itself will be very, very thick, and I will not be able to go beyond that, and I will not be able to put the scope beyond that. In a posturethral valve, I have to negotiate the bladder neck and go beyond the bladder neck, and then I will see the valve. Here you won't be able to see. As if you're going into the bladder and suddenly you're seeing a small round area which is representing the neck, and then I can't go beyond that. So that is urethral atresia.
Thank you. I think I have one question about the diagnosis. When in this Ruano's criteria, renal dysplasia is one factor, echogenic kidney is another, cortical cyst is another. Oh, so if you say echogenic kidneys and cortical cyst as separate criteria, what exactly is renal dysplasia on your ultrasound?
Correct, sir. So the way they describe it is in the initial stage. These are all stages of the whole spectrum. The initial stages, the renal echogenicity is increased. Then the next stage, what happens is cortical cysts start appearing. Dysplasia, obstructive dysplasia, is the cortical cysts are extensive. The kidney actually becomes smaller in size because initially the obstructed kidney will be large in size and it can also be echogenic. Then with the cortical cyst forming, the kidney becomes smaller, and the dysplastic kidney is a small kidney showing multiple fine cortical cysts, which you may sometimes be identified only on zooming a lot, and then you can find these tiny cortical cysts which are there. So that is the final endpoint. So it's a spectrum.
Okay. I think couple of questions and then we will, so it says, is there a role for MRI to distinguish between PUV and atresia prior to procedure?
Role of MRI.
Fetal
Okay.
MRI, yeah.
Yeah, I don't think MRI is required because we will we'll be able to the sensitivity and specificity of fetal MRI in differentiating between these two has not been proved as yet.
Okay, I think one last comment from Dr. Sareen. He says, is it dysplasia a histopathological diagnosis?
Yes. I agree that dysplasia is a histopathological diagnosis. But what has shown that when you see these small kidney with cortical cysts which are there in the background of an obstruction, invariably the histopathology will show you obstructive dysplasia. So it's a very good correlation between ultrasound and histology. So we'll be able, in the milder degrees of dysplasia, we may not be able to make a differentiation, but in its severest form, you will be able to call a kidney a dysplastic kidney because it will be small, shrunken, and have the altered echogenicity with cortical cysts.
I'll just
Sanjay, sorry.
Yeah.
There was one question on what is the procedure cost. I thought Suresh can address it before he goes.
Okay, so procedure cost. See, fetal cystoscopic fulguration with including cost of the theater, about two days hospital stay, all that may come to somewhere around 70 to 75,000 rupees.
Okay, thank you. One last question. I think this is a question for both of you. I think, say you have a child, a mother who's 26 weeks, now begins to show oligohydramnios. What would be your choice? Would you deliver this kid at 30 weeks and look after a premature baby? Or would you do something at 28 weeks and try to pull on the pregnancy for longer?
I think my choice would clearly be to do something and prolong the pregnancy, because delivering a baby as an extreme preterm is such a hassle, and you're exposing them to a whole set of new problems outside. And that is, and not only that, ultimately the cost of management in an NICU, that level of care, not many NICUs can provide, and it can be, the outcomes are not great in terms of neurodevelopmental outcomes also.
My choice will be at 26 weeks, definitely the choice between delivering and doing an intervention to improve survival rates, but with extensive counseling to the parents, telling them that long-term renal outcome is not something we will be able to tell you about, but certainly this baby has a higher chance of survival by doing the procedure. Because there are parents who come, one of our patients is 15 years infertility. She has conceived, and for her, the only thing is she asked me whether I'll be able to hold my baby for at least a few weeks. If there's any complication, I'm willing to take it. Now that boy is about 8-9 years old now, but still having some problems, but still she's very happy that I've got a child and doing that. So it's a parent's choice to make that after doing extensive counseling, but choice is to do intervention and not to deliver the baby at that time.
Right. I think on that note, I think we have covered all questions and we have had a very, very interesting discussion. Very precise, very unambiguous, very clear. So thank you both to Dr. Sripathi and Dr. Suresh for taking time and addressing this topic. We had hit the 100 limit on Zoom, and there were people watching on YouTube. So I think it's been a good meeting. This will actually go up on YouTube a little later as well. So I thank you very much for your time and for your expertise. And I hope this sort of excites more of our younger colleagues, to explore these areas, which I think are areas that are, things that as pediatric surgeons who are looking after and counseling patients, we must have this kind of background information. So thank you, gentlemen. And thank you for all our colleagues who attended this meeting and participated in discussions. Thank you very much.
Thank you, sir.
Thank you.
Good night.
Thank you.
Bye. Good night.
Thank you. Good night. Thank you.
Right.